respected chairpersons, moderator, discussion, teachers, colleagues, and friends. I highly appreciate the Sky to giving me the opportunity, especially Professor Ghulam Azam, to present in this August gathering. I slightly apologize by changing my topic of my slide. I was given my CTO complication, but I want to prepare my case as high risk CTO, high we prepare. This is a gentleman of 60 years who is hypertensive, diabetic, and smoker with CCS, chest pain with CCS class 3 and 4. ECG shows T inversion in the anterior leads with T upright in the AVR, ST segment upright in the AVR. His echo reveals wall motion abnormality with ejection fraction 50%. A patient was admitted to the hospital for routine angiogram, but he developed severe chest pain and hemodynamic instability in the morning of the next day. He was brought to the cath lab immediately, and angiogram was done with the extra backup catheter. And because the ECG reveals that there might be left main disease or a severe triple vessel disease, so left main is totally occluded just after the ostia. So the patient was hemodynamically unstable and there was chest pain. So we punctured the left femoral and took the guide catheter to the right side, and we saw that right system is dominant and the right coronary feels the whole of the left system. The issues are the left main is totally occluded just after the ostia, which was appropriately filled from the right system. Patient has ongoing chest pain. Patient is hemodynamically unstable and gross STD change in all leads. And we main treatment options are urgent CVG was an option. We talked to the patient's party and planned for the urgent PCI. The guiding run through with microcatheter was taken, and run through was not negotiating, and we then changed into a pilot wire, and we negotiate, and the wire crossed into the LCS by contralateral injection from the right side, and pilot 50 was changed with the run through floppy wire in the LCS. Now, techniques of entering the CTO from the side branch. There are several techniques used. There are the use of intravascular ultrasound to clarify the entry point of the CTO may be an option. And Cyto, the great operator of CTO, had talked on open sesame technique. This technique is use of high support guide wire and the inflation of the side branch that changes the geometrical configuration of the CTO. It is stated by Cyto. This might be option for opening the side branch. And Kato, also a great operator of CTO, described the usefulness of dilating the ostia of the proximal side branch at the entry point of the CTO with the small size balloon or tonus catheter device. And importantly, the wiring of the side branch on the baseline condition and the absence of dissection affecting the bifurcation or trifurcation were the powerful predictors of technical success in the side branch CTO wiring. In this technique, about 75%, 74 to 75% was the success rate. So we proceed to the last option, and we wired the ramus with the same technique, with the contralateral injection, and trying to negotiate the wire in the LED by the help of microcatheter with contralateral drive. After all effort, we can after contralateral injection, we can cross the wire in the LED with contralateral injection, and we are in the right track in the anterograde CPO intervention. The pilot 50 in the LED was changed into a run-through wire with the microcatheter. The left main is dilated with the 2 into 10 millimeter followed by 2.5 into 10 millimeter NC balloon. And after the dilatation, you see the left system is visualized and there is trifurcation lesion and the left there is left main disease. And we did the IBUS, checked IBUS. You see this, there is calcified lesion in the left main and the proximal part of the LED. So we aggressively predilate the left main with the proximal LED with 3 into 12 millimeter NC balloon. And we did the kissing with the balloon, left main to LED with 3 into 12 millimeter balloon, and in the left main to L6 with 12 into 2.5 millimeter balloon. And we did the IBUS after the kissing, and this time the vessel was wide open. There was ostial L6 were good in this view. So we put a 3 into 38 millimeter drug electric strand from the left main ostia to the LED. By contralateral injection, we confirm the position of the strand. We dilate the stent in the left main to LED. The mid part of the stent was poorly opened and going up to high pressure. And the stent of the left main to LED is pulled back and going to high pressure. The stent is well inflated. After stent inflation, we see the left system is good, the flow is good, LCX and Ramas is narrow caliber vessel, and post dilatation was done to the LED with 3 into 8 millimeter NC balloon, and post dilatation done in the 3.5, 12 and 4 into 12 NC balloon in the left main. And on contralateral injection from the right side, we see that left system is not filled up by the right side now. So all the vessels are widely open up. And we did an IBUS. The stent is widely opposed. We see the ostia of the LCX, and the left system is well. All the stent studs are widely open. This is the final result with the single stent strategy in a trifurcated left main lesion. You can see the LED is well, left main is widely open, LED is good, and all these vessels are widely open. So take home message is the presence of a bifurcation or trifurcation at the proximal or distal entry point of the CTO has been described as an anatomical predictor of failure. The failure incidence of failure is about 25%. Different techniques available to overcome this problem. Wiring of the side branch at the baseline condition and the absence of dissection affecting the bifurcation were powerful predictor of technical success. The rate of technical success was about 74%. Single stent strategy is the default technique, choosing the strategy in bifurcated and trifurcated lesions if possible. Choice of strategy depends on a vessel and vessel characteristics, mainly the blood distribution, diameter of the stent, angle of the disease, and anatomical side branch. And I highly acknowledge Professor Fazila Malik Madam for my mentor for preparing this case. Thank you from our cath lab team. Thank you all for patience hearing.